Good morning, fellow pharmacists. My name is Sandy Gabriel. I'm a post-baccalaureate PharmD student at Massachusetts College of Pharmacy and Health Sciences. And today I'll be speaking about schizophrenia. So the objectives of this presentation will be to describe the epidemiology and pathophysiology of schizophrenia, to identify the risk factors and complications of schizophrenia, to review the most updated guidelines, and to discuss the proactive trial. So there are 2.2 million Americans that are 18 years and older that are affected with schizophrenia, and around 51 million people that are affected with schizophrenia worldwide. Schizophrenia cost the United States about $63 billion a year. And in 2009 to 2011, there were 382,000 emergency department visits for patients that are 18 to 64 years old due to schizophrenia. The pathophysiology of schizophrenia is complex, but to simplify it, it's a hyperactivity of the hippocampus that leads to excessive firing of dopamine neurotransmitters into the synapse of dopaminergic neurons. And there's the over-responsiveness of the dopamine receptors to dopamine. The risk factors for schizophrenia include the place and season of birth. So people that are born in urban cities or in the winter season, they are at an increased risk of developing schizophrenia. Also, pregnancy and birth complications. So if the neonate has a too low or too high vitamin D levels, they are at risk of developing schizophrenia. Also, preeclampsia, malformation, and vacuum extraction could also increase the risk. Infections with influenza and measles during pregnancy could also increase the risk of schizophrenia. Drugs and substance abuse. So for the lysergic acid diethylamide, also known as LSD, phencyclidine, methamphetamine, cocaine, opiates, alcohol, tobacco, and cannabis, they could all increase the risk of schizophrenia. Childhood trauma, head injury, family breakdown, or death in the family, and a family history. So if an offspring or a person has one parent with schizophrenia, they are at the risk of, they are at 13% risk of developing schizophrenia. And if both his or her parents have schizophrenia, then the chance increases to 20%. Complications of schizophrenia include suicidal attempts, anxiety disorders, obsessive compulsive disorder, depression, alcohol and substance abuse, the inability to work or to attend school, and the patient will usually have financial problems and homelessness, social isolation, health and medical problems, and aggressive behavior. Aggressive behavior is usually not very common, but it's present in patients who have delusions. The goals of therapy are divided into short-term and long-term. The short-term include to reduce the severity of acute symptoms and to return the individual back to their behavioral baseline. The long-term include to prevent the recurrence of acute symptoms and to increase the patient quality of life and maximize their functioning. So the most updated guidelines are the American Physician Guidelines, or also known as APA guidelines, and they were updated in summer of 2020. So the factors that would influence our choice of drug therapy would include the patient risk factors. So say if the patient have anxiety or poor sleep, hallucination and delusions. And it will also depend on the patient's or the caregiver choice. So the factors that would influence the choice of therapy would include the drug formulations. So say if the patient has a difficulty in swallowing, we would give them an oral disintegrating tablet. And if they have problems with adherence, then we will prefer to give them a long-acting injectable. Also, drug-drug interactions are very important to be taken into considerations because antipsychotics, they are very highly plasma protein bound. So we need to analyze the patient's drug profile to see if they're on any other medication that's highly plasma protein bound. And in this case, we should decrease the dose of either the antipsychotics or maybe both medications. Also, the pharmacokinetic interactions should be taken into considerations because the presence of food in stomach highly increases the absorption of antipsychotics and the adverse effects of the medication because antipsychotics, they have a wide range of side effects. An example of them is weight gain and hyperlipidemia. So in order for a response to be seen or an initial response to be seen, it takes about 2 to 4 weeks from the date of initiation of the antipsychotic to see any response. And for a full response to happen, we need to give the patient a period about 4 to 6 weeks. So a proof of efficacy is within 2 to 4 weeks, we should see at least a 20% improvement in symptoms. And by the 4 to 6 weeks, we should see either a full response or 50% improvement in the patient. So it's really important to schedule a follow-up or to reassess the patient within 2 weeks from starting the antipsychotic to determine the responsiveness of the medication. So, so antipsychotics, they are divided into first generation and second generation. First generation antipsychotics include chlorpromazine, fluphenazine, haloperidol, loxapine, molindone, perfenazine, pimozide, thioridazine, thiothexine, and trifluperazine. And the second generation antipsychotics include aripiprazole, asenapine, brexpiprazole, cariprazine, clozapine, iloperidone, lurazidone, olanzapine, paliperidone, quetiapine, risperidone, and ziprasidone. And the second generation antipsychotics are more common in use than the first generation antipsychotics. So now we will discuss the adverse effects of antipsychotics. The first one is hyperlipidemia, and it's most commonly seen with clozapine and olanzapine. So we have to make sure that the patient is not hyperlipidemic, and if they are, then we have to give them an anti-hyperlipidemia medication. Myocarditis is usually seen with clozapine, and deaths due to myocarditis have occurred within the first month of starting treatment with clozapine. So we have to monitor the patient closely. Orthostatic hypotension is also common with clozapine, and it's most commonly seen in elderly and in patients with cardiovascular comorbidities. So in those patients, we should titrate the dose of clozapine really slow and to monitor the patient. QT prolongation is seen, or it's most common with chlorpromazine, thioridazine, ziprasidone. We should analyze the patient drug profile to see if there's any other medication that would prolong their QT interval, or if there's any medication that's highly plasma protein bound. Such medications, they should be avoided in females, elderly, or patients with other cardiovascular comorbidities, because those are the ones that are at the highest risk of developing a QT prolongation. Tachycardia is common with clozapine and olanzapine. The endocrine side effects is usually seen with olanzapine and clozapine. They increase the risk of hyperglycemia. Hyperprolactinemia, it's seen with haloperidol, palperidone, and risperidone. So if the patient develops a hyperprolactinemia, we should either switch the medication or we should administer bromocriptine. With the sexual dysfunction, there is a loss of libido that happens with both males and females. And in males, they might experience a retrograde ejaculation. And this is most common with thyroidazine and risperidone. GI side effects include dry mouth and constipation, and they should be reported to the clinician as soon as they experience, because they could develop to paralytic ileus. Hematological disturbances are mostly seen with clozapine. Dystonia is more common with the first generation antipsychotics, which include haloperidol, thiofexine, and flofenazine. Akathisia is also more common with the first generation antipsychotics, and also the haloperidol, thiofexine, pimozide, and flufenazine are the ones with the highest risk for that. Parkinsonism is also more common with the first generation than the second generation. And that also applies to the tardive dyskinesia. Now I will discuss the proactive trial. So Beckley et al., they did a trial to compare the occurrence of a second and third relapse of an acute psychotic episode in patients that have experienced a first relapse. And the patients were either receiving an oral or an injectable antipsychotic. So 305 patients with schizophrenia or schizoactive disorder were randomly assigned to receive either a long-acting injectable risperidone or an oral second-generation antipsychotic medication for 30 months. 109 patients experienced one relapse. From those 109, 61 over 146 patients were taking a long-acting medication, and 48 over 150 were taking the oral medication. There was no significant difference between the two groups in the time to first relapse. 32 patients experienced 2 relapses. Out of those 32, 16 that were on the injectable group, and also 16 in the oral group that developed a second relapse. There was no significant difference between the two groups. 13 patients experienced 3 relapses. Out of those 13, 5 in the injectable group and 8 in the oral medication group. But there was also no significant difference between groups in the time to the third relapse. So the conclusion of this trial is that both oral and injectable medications have similar efficacy in the time to relapse of the second and third active schizophrenia disorder. And that brings the end of my presentation. If you have any questions, please give me a call at 407-388-8997, or you could email me at Sandy, S-A-N-D-Y, Nadir, N-A-D-I-R, @hotmail.com. And thank you for listening. Have a great day.